Good evening. All right, I would like to get started and just introduce our speakers and talk a little bit about Manhattan Psychology Group. So today, Chelsey Rosen and Claire Romero are going to be talking about an evidence-based treatment for selective mutism, PCIT, SM. And I'm going to talk more about our speakers after this. Okay, so I just want to talk a little bit about Manhattan Psychology Group. Chelsey has recently provided a specialized selective mutism training for BCBAs at Manhattan Psychology Group for the BCBAs who are interested in working with this population. And so that's what's really nice about Manhattan Psychology Group is that we have a multidisciplinary team and we see psychologists working with BCBAs and collaborating to make a difference. So Manhattan Psychology Group is the first company and that's the company in which the psychologists and BCBAs work and provide direct services to clients. And those clients are private pay or DOE funded clients. We have LBAs, BCBAs, and permit holders working in that company and providing direct care services to our clients. And then MPG tutoring is similar where the BCBAs, special ed teachers, I think we have LBAs, BCBAs, and special ed teachers providing tutoring services to our clients. It's very similar to the first one, Manhattan Psychology Group. And then MPA, Manhattan Psychology Associates, is our insurance model where our clients are receiving ABA services through their insurance and BCBAs are supervising RBTs and behavior techs. And there's tons of opportunities. Our BCBAs and special ed teachers and RBTs are working across the three companies. More the BCBAs are working across three companies, and this is just one big company with three sub companies. Okay, so we all kind of work together. Our mission at Manhattan Psychology Group is to change the trajectory of individuals and their families who experience psychological, developmental, and educational challenges. So we have a big group, a big dynamic of our clients. And our vision is to create a future where these individuals feel confident and they lead autonomous and fulfilling lives, and they're able to make meaningful and connect with people in their family and community. So a little bit about this webinar event. I'm going to put a link to the survey in the chat at the end. So there will be two codes. You need to record those codes, and in the survey, it's going to ask you for those two codes. So please make sure when a code slide comes up, write down that code and don't forget it, don't lose it. You'll need it for that survey. Once you fill out the survey, you'll need to fill out the survey by this Friday, 9 a.m., November 25th. If you don't submit it by that date, you won't be able to get a certificate. Okay, the certificates are for BCBAs and non-BCBAs. So BCBAs will get a CEU. If you're not a BCBA, you will get proof of attendance. And that will take about 2 weeks from November. So please give us time because we have someone on our team creating those certificates. Okay, so in about 2.5 weeks, you will be getting your certificate. Please remember to complete the survey. And I'll also put my email in the chat if you have any questions or have any difficulty with that. There's also going to be a recording available. The recording will be available by December 1st, probably sooner. It's going to be on our calendar and in the MPG website, and I will post a link to our calendar in the chat also. So you will have a link to the chat, you will have a link to the calendar and the survey in the chat. We are also going to, like I said, there's going to be a recording, but the slides are not going to be shared. So anything you want to jot down, please feel free to do so. If you're a BCABA, yeah, this counts as a CEU. Thank you for asking. Okay, so I just wanted to introduce our two speakers. Chelsey Rosen is a New York State licensed psychologist and a certified New York State school psychologist. She received her BS and her bachelor's in psychology from the University of Maryland, College Park, and her doctoral and master's degree in school psychology from St. John's University. Dr. Rosen is a certified therapist in parent-child interaction therapy, which is PCIT, and selective mutism. She's a selective mutism specialist, and she's actually trained a group of BCBAs in Manhattan Psychology Group to implement these strategies and this intervention And Claire is going to bring in the ABA component and share how this applies to ABA and how she can use this in an ABA, use this intervention in an ABA session. We've been talking a little bit about, you know, how do we take data, how do we graph the progress, and how do we make this kind of fit into our ABA world, right? So Claire took Dr. Rosen's training, and she just loves working with this population, and they both want to share this with you. So thank you so much, Chelsey and Claire, for sharing this information today. I'm looking forward to it. I'm sure everybody here is. And today, the topic is evidence-based treatment for selective mutism, which is PCIT-SM.
Thank you, Kristen. I'm really excited about this because I have done this training, like I can't even count how many times, but we just started having the BCBAs join us and get the training and kind of see how much overlap there really is with ABA and the treatment that we do. And the reason why we started doing this training with the BCBAs is because during COVID especially, we were getting so many referrals for selective mutism. And as you're gonna see with the presentation, is a lot of the treatment is us going into the homes, us going into the schools, and it's more of like an intensive model. And we just couldn't keep up. I couldn't keep up. So we were like, how do we reach more families? How do we reach more schools? And how do we reach more professionals? And so we started this program, and I'm really excited to combine with Claire and really talk about it. Claire, if you want to share a little bit about why you took this training and a little bit about you.
Sure. I've been a BCBA since 2007. So in those 15 years, I've worked with individuals on the autism spectrum. About a year ago, I started to think that I really wanted to do something a little bit different, but still could utilize the skills that I have. And within a few months, the scope of restriction in New York State was lifted. For those who are joining from out of state, in New York State, we were only allowed to work with individuals on the autism spectrum in our field of ABA. So this has been fought and it was lifted, and it's fantastic. So now we can use our skills with any sort of diagnosis. So when that was lifted, MPG reached out to all of the BCBAs and opened up this opportunity to train with Dr. Rosen, Chelsey, in regards to how to treat children with selective mutism. I thought, wow, this is fascinating. I know of selective mutism, but I don't know a whole lot about it. But I'd love to do this. This is exactly what I've been asking for. So we started initially with a very similar training to what you all are going to hear tonight. And we did in-person and online trainings and role plays and hours and hours, countless hours together, practicing coaching and practicing all the skills you're going to hear today. Very soon after, we started getting clients. And with those first clients in particular, Chelsey really walked us through step by step and was there and helped us and coached us coach the parents and the teachers. So it was a really great first experience to really build confidence. Since then, I've had a few more clients that I always check in with Chelsey. She continues to supervise me. Every time I talk to her, I learn something new. I'm sure tonight I will still learn something new because this is still a very new area to me, but it's just been so rewarding. And it's been a very easy transition to go from working with individuals on the autism spectrum to working with individuals with selective mutism, because a lot of these skills and a lot of these techniques that you're going to hear about tonight are so similar or actually the same as what we do in our ABA therapy with individuals with autism. So a lot of what you hear tonight might actually not be new information to you, but when we put it all together, that's what makes it so powerful and effective for kids and adolescents and adults with selective mutism. Okay.
So our objectives for today. So we want to learn about common comorbidities with children with selective mutism. And we're also going to learn about and how to implement an evidence-based intervention. So like you guys are BCBAs, psychologists, we love evidence. And so this is one of the evidence-based interventions for selective mutism. And at the end, I'm going to have a reference page with all the research, so you can feel free, if you want, you can email Kristen and she can send you that too, so you can read up about it. So just really quickly, I just wanted to show what the DSM criteria is. And so basically it's consistent failure to speak in specific social situations where speaking is expected. So for example, most of these kids, not all, but most of these kids do speak at home totally normally. Some have speech delays, some don't. And we see if it's despite speaking in other situations, if they're failing to speak in a specific situation. So like this says, school is the biggest one. We want to make sure that it's not within the first month of school. As all of you know, some kids are actually just shy and slow to warm up. These are not kids that are shy, so we would never give a diagnosis within the first month of school, or within the first month of seeing these symptoms. It's not better accounted for by a communication disorder, and it's not exclusively due to autism, schizophrenia, or other psychotic disorder. As we'll talk about, it is a comorbidity with autism sometimes. So you can have both autism and selective mutism, but just because you have autism doesn't mean you have selective mutism, and vice versa. So why is it so impairing? So these are all examples of things I've seen. So you have an accident because you're unable to ask to go to the bathroom, you're not participating in assignments, you might have a cut and you don't tell anyone. We had a kid who actually broke his arm and never told anyone until he got home. He was so anxious that a teacher didn't even know. You're unable to share about your weekend with your friends, and you also might have difficulty making friends because you can't share with them. So I like to add this slide, what selective mutism is not, because I think it's so important that selective mutism is not oppositionality. It often looks like it because we all know most of the time that these kids do speak. And so when they're not speaking to us, it seems like they're being oppositional. It's not trauma induced. Thankfully, this myth is sort of going out the window. But when I started over 10 years ago, this was like a big one that parents would come in and say, something must have happened to my kid. There's no research to show that it's trauma induced. Again, it's not autism. It's not just shyness. It won't go away on its own. Like we talk about with autism, early intervention is really key with this. So as soon as a parent comes in, we're starting treatment pretty quickly. Again, it's not the same as social anxiety, although again, this is often a comorbidity. So we're going to talk about that a little bit as well. So Claire, you want to talk about?
Okay.
Yeah.
Yes. Sorry, I just realized I was on mute. So the first assessment tool that is used is called the Selective Mutism Questionnaire. This is a questionnaire that is given to the parents before they do their intake with Chelsey. Basically, it just assesses where and when their children speak. Then they'll do the intake, and then after the intake, there's the selective mutism baseline observation task, which we call the SM-BOT. This is essentially our baseline observation. We are watching to see how much these children do speak with their parents, and I will go through this in a few minutes and what's really entailed with the baseline observation, but that's what the next step would be. Okay, and the next slide. Okay, so what is the SM-BOT? It's that baseline observation. We want to see what happens with the parent and child and when they're alone. We typically do this in the office, but you can do this virtually. So we watch the parent and the child through a one-way mirror. We have headsets so we can kind of guide them along what we want them to do. So we just set up a bunch of toys. We watch them play. We have them engaged. Everything is scripted down to exactly what we say and the timing of things. And we will prompt the parents to engage in specific ways throughout this baseline observation. After some time, we'll have a stranger come in the room. The stranger is usually another clinician, or it could be an office intern. And the stranger, when prompted by the coaching and observing clinician, will ask one question to the child. We want to see, will the child answer? What's the quality of their answer? Is their voice very low? Is it loud and strong? Do they use a gesture to answer? Do they look at their parent and answer? Do they not answer at all? So we are looking to see what happens if this stranger comes in. Then we'll have the stranger leave, and we go back to the parent and the child alone in the room again, playing, interacting. We're all along, we're taking data and we're tracking these verbalizations that are occurring. We have the stranger return, the same person, and we go through that process again. We prompt them to ask a question and wait to see what happens, record that, and then see what happens. Then we will actually leave the stranger in the room, but prompt the parent to leave. And we're looking to see what happens with that separation. Often there is a separation anxiety that goes along with this. So we're looking to see if there's any sort of behavioral issue when the parent leaves and the child is alone with the stranger. They're only there for a few minutes. We have the parent tell them they're going to leave. They'll be right back in a few minutes, and then they do come back. And then the SMBOT process is complete. Okay, so here is where we want to talk about what is this ABA connection. We have an ABA connection here. Chelsey, can you click that and see if that pops up?
Do you see the poll?
Oh, I do see the poll. Okay, so the poll popped up first. That's fine. So what research design does this sound like, right? This brought me back to those early days in my training, and what does this sound like to you guys? Let's give this another minute or so. It looks like about half of you have answered.
Yep.
Oh, you closed it out already. Okay, great. Sorry. Yes, it looks like most of you answered AB reversal design. That's exactly what we're doing, right? Where we have that baseline of the parent and the child. We're adding in that variable of the stranger. We're removing that variable and going back to baseline with just parent and child, and then we put that variable back in place. So we want to see as we alternate. Great, good job.
And for the psychologist, if it's bringing you back to staff your first year, this is the bane of my existence. That's another connection.
Right, perfect. Okay, so why can selective mutism often be misdiagnosed as autism? Because this does happen. But we should also just make a quick mention that you can have an autism spectrum disorder and also have selective mutism. This is actually possible. They're not mutually exclusive, but it is not uncommon for an individual to be diagnosed as being on the autism spectrum as opposed to selective mutism when it's really selective mutism. So why does this happen? Because we see that these kids often have difficulty maintaining eye contact, which obviously goes right along with autism spectrum disorders. They may look like they prefer to play alone, but in reality, kids don't want to be alone. They want to be playing with other kids. They want to be talking to their teachers. Their anxiety is so crippling that they just physically cannot. They may often have rigid behaviors. So they may be kind of controlling what they can control. And if that's how they play with toys and how they interact with materials and how they kind of manipulate their environment, if that's what they feel is in their control, that might be something that we see. And they often follow their own set of rules in regards to talking. And I said that this could look like a nonverbal type of autism when there's no speaking in the school environment. So the teacher might say, well, this child doesn't speak at all. They're in 5th grade, they're not speaking, there must be something going on here. But what this means is they follow their own set of rules is these kids live in a divided world. There's their not talking world and there's their talking world. Every child's rules are very different. So some kids might talk in school and might not talk in school, but they talk at home. That's typically what we're working with. But some kids will talk in school, but only talk to their friends and not to their teachers. Some kids will talk in home, but only to mom and dad and their brother, and not their grandmother, grandfather, aunt, uncle, cousins. So it's very, very different for each kid what their kind of divided world looks like. Typically, home is not a contaminated place, but like I said, there is situations where that could be.
So I'm going to talk about how selective mutism is maintained. And I actually think this is one of the most important slides to know for selective mutism and also for anxiety in general. So Dr. Kurtz, Steve Kurtz, who developed PCIT-SM, who we're going to talk about in a little bit, he came up with this. And I think it's super, super helpful because it helps us learn how to treat selective mutism as well. So what typically happens is a child is, let's say, 3 years old and is prompted to talk or engage. So she goes to the supermarket with her mom and someone comes up to her and says, "Oh my God, you're so cute. How old are you?" He gets super anxious. So what does she do? She hides behind her mom. What then happens? Mom gets anxious. Child avoids. Mom's anxiety raises and child's anxiety raises. Adult says, "Oh, she's 3." Child and adult anxiety is lowered, and then it's this negative reinforcement cycle. And this is exactly what we have to break. Now, when we're talking to parents about this, and we're talking to teachers, and we're talking to therapists about it, it's important to say that this is typical. Like if someone tells me, "Oh, I've never answered for my child," or "I've never let her avoid answering," I would say there's just no way, because good people accommodate. It's really, really hard not to. And so we teach everyone that while we know that this has been happening, it's our job now to sort of break that. And we'll talk about how we're going to do that in a little bit. So PCIT-SM, like we talked about before, is parent-child interaction therapy for selective mutism. Dr. Sheila Iberg is the one who came up with PCIT. And what PCIT is, if you're not familiar, is a treatment for kids with oppositional defiant disorder. Dr. Kurtz developed it for kids with selective mutism. Now, also when I'm talking about this, it's interesting because I just told you all that kids with selective mutism aren't oppositional. But what Dr. Kurtz figured is that if we can help kids self-regulate, learn how to self-regulate when they're really oppositional and they're really dysregulated, why can't we do the same for kids with anxiety? And so he adapted it for selective mutism. And there's also some other adaptations for other anxiety disorders. And again, like I said before, the articles are cited on the reference page. But what is selective mutism? So what it is our goal is to provide opportunities to practice being brave in all different situations. So we're slowly increasing difficulty in terms of verbalization and where we expect kids to talk. So we're not going to say to the kid on the first day, "Okay, you're going to go do a presentation," but we'll slowly have them talk in higher stress situations. It definitely increases the stress tolerance. It's always a disclaimer I say. It's anxiety provoking for both us and for the kids. We know that we're having them do something that makes them anxious. And also, we know that by making them do something or having them do something that makes them anxious, again, slowly increasing the difficulty, then they can learn that they can do it. And we see a lot of success. Like Claire was saying before, it really varies from kid to kid. And so when parents will say, "How long is treatment?" Like we really don't have an answer to that. But if we really get all buy-in, it really should be quick in terms of the meeting with us. And we'll talk about that in a little bit. We are super transparent with kids. We tell them that they are working on brave talking. We never will say, "Oh, I heard you talk." We're really working with them, and we call it brave talking, especially with the younger kids. With the older kids, we're just very transparent and like, talking is hard for you, and that's what we're here to help with. It does often require medication along with treatment, but not always. So Claire added
Yes.
a ABA connection here.
So our little connection, right? So little side note, when I went through this initial training with Chelsey and she was going through this information, I was like, "Oh, that's generalization. Oh, that's shaping." So I just popped those in here too. As I'm sure all of you BCBAs are out here thinking, wow, okay, so she's calling it scaffolding, slowly increasing the difficulty. We're talking about shaping here, right? Reinforcing successive approximations to that ultimate target behavior, right? And that providing opportunities to practice being brave in different situations. So we're talking about generalization, right? Generalization of people, of places, of stimuli. We're just looking really at the same types of things here.
So what are our goals for treatment? So we want to increase verbalization to as many people as possible and as many places as possible. I always say to parents about any anxiety, honestly, is that my goal is not that your child is necessarily the one that's on stage doing backflips and singing cheers at the football game. Although, if that's what we think we want them to do, that is my goal. So we want our children or whoever we work with to be able to participate in any activity that they actually want to participate. That is our goal, is that they become the person that they see at home. And I think for parents, that's often the hardest part for them, because honestly, most of these kids that we work with are not shy at all. They're actually like super outgoing, super funny, but no one is seeing that side of them. And again, we want to decrease avoidance and enabling, which we're going to talk about a little bit later on. So what is a typical treatment plan? So we have the intake, they come in like anything else. Then we do that behavior observation task that Claire had talked about. Then we train the parents on the skills. And then we do something that we call like an intensive treatment sessions. And so what's different about typical therapy is that we aren't meeting with these kids and their parents once per week, 45 minutes, and then sending them home. We're really, really front loading. So we have them come in, we coach the parents through that one-way mirror that Claire was talking about, and we're actually teaching them to be the therapist. And so what we typically do, depending on severity, is we'll have multiple sessions in 1 week for multiple hours. So we might have 2 days in a row for 4 hours. And so what we're doing is we're building up the parent skills and also getting the kids very comfortable. And then we're slowly fading ourselves in. And we'll talk about fade-ins in a little bit. But what we find is that if we do weekly treatment, by the time we get a kid comfortable, they're leaving and then they're coming back the next week. And it's very, very unlikely that they'll start talking. So if we do it in an intensive way, typically we will help kids talk to a new person within that first week, which is actually pretty amazing if you think about it. We sometimes will see kids that have never spoken to anyone but their parents, and by the 4th hour, they're verbal with one of us, or at least in front of one of us. After that, we'll train the teachers on the selective mutism skills. Again, our goal is that we are training the people that are in the kids' life as much as possible, because as much as we want to be involved, we're not with the kids every day. These people are. And so we train them. And then if needed, it's not always needed, but a lot of times we do, we'll go into the school and we'll coach the teachers in the school. And then we do also have community exposure. So ordering ice cream, asking for a napkin, asking a police officer for directions, all these things that are really, it's a real life treatment. Our goal is to make them as functioning as possible in a real world setting.
Okay, so now we're going to start to kind of get in the nitty gritty here. So now we're going to talk about child-directed interaction. This is the start of, and now we've done the intake, we've done the SM-BOT. Oh, wait, let's pause here for a second so you guys can write down code 1. You have a few seconds to write this down. All BCBAs, you need this code to get your CEU credits. So please write down your code. You'll have to input it in the survey upon the completion of the webinar. Write it down. It's the words. It's not the picture. No problem. Okay, let me know when you're ready.
And I'm just going to say the code too. It's child directed.
Okay. I don't think you'll need the quotes. It should be multiple choice, correct?
Yeah, you'll have to select select two. So write down child directed.
Okay, great. Okay, so we've done our intake, we've done our SM-BOT, which is our baseline, and we use that baseline to really determine not only what the child's verbalizations are like with that familiar adult, which is typically their parent that we start with, but also what kind of coaching are we going to need to give the parents. So when we start with our intensives that Chelsey just mentioned, the first thing that we work on is CDI. So what is CDI? This is a warm-up. We're following the child's lead. We're going to incorporate pride skills, which I'll go over in a second very quickly, and it helps children learn how to self-regulate. And this is a time when there's no questions or no commands. This is a fun time. This is no pressure. Okay, next slide.
I just want to add something that it has nothing to, it has to do with selective mutism, but I also think CDI, what we're about to go over, these child-directed interaction skills that are from PCIT, I really think it's so important even to use with all kids separately, not even just selective mutism. We're actually starting to do it in hospitals with trauma patients and with adults even, because the more we ask questions when kids are anxious and adults, the more anxious they actually become. So just, I wanted to add that because I think it's just so important for all kids. And so not just kids with selective mutism or oppositional defiant disorder.
No, I find myself doing this now in my sessions with my kiddos on the autism spectrum. So it's it kind of becomes ingrained in you, and it's great. We also do ask our parents and teachers to do at least 5 minutes every day of this, because we want this to really be a rewarding type of experience. So the pride stands for praise, reflect, imitate, descriptions, and enjoyments. We're avoiding questions, commands, and negative talk. And so why are we doing labeled praise, right? We want the children to know exactly what we want to see more of. This increases the behavior that that we're describing. It increases their self-esteem. So it's going to sound a lot like, thank you for telling me. Thank you for using that loud voice. Thank you for using a brave voice. I love it when you say thank you. And what is this connection here? This is no surprise. This is what we call behavior-specific praise. It's the exact same thing we do every day with our kids with autism and whatever other diagnoses we may be working with in our ABA world. This is what we are really good at, and we should be doing this. And we do this constantly. Okay, we also work on, we're going to be working on reflections during this time. This is repeating exactly what the child says. We're echoing the child. The child's not echoing us, we're echoing them. So we want to increase their verbal communication. We want to improve and increase their speech and language. It lets others know that they can talk. And this is important because there's a lot of times adults or other people, other kids might assume that these kids can't talk. So when they are talking to us and we're repeating what they're saying, other people are hearing what these kids are saying. So it's validating that these kids actually can speak. And it's also letting the kids with selective mutism know that other people are hearing what they're saying because we've just repeated it back. So the child might say something like, this is a tower. If they're building, they say, oh, a tower. And then we usually will follow that up with great talking. Thank you for telling me. It kind of goes hand in hand. We're going to imitate what they're playing with. It helps. Not only does it help us stay on task, but it makes the play fun. It's showing approval in what they're doing. It also will teach them how to play well with others, because like I had mentioned earlier, sometimes they're not interacting with other children. So those social skills might actually be a little off. So this will kind of help reinforce those types of skills as well. And then we are behavior descriptions. I love that you put sportscaster in here. Yes, that's hilarious. Yes, we are describing everything that we see. It's us doing a lot of talking during this time. We're taking the pressure off these kids with selective mutism, and we're taking the heavy loading with the talking. So we're giving a lot of specific attention to what they're doing. We're modeling speech, and we're teaching appropriate language. It keeps us both engaged. So we might say things, it might sound like, oh, you're drawing a castle, you're walking to the room, now you're putting the trains away, you got the Legos, like you put the green Lego next to the red Lego. You're literally just describing everything that you're doing. I do this a lot when I'm working with my kiddos with Play-Doh. Oh, I see you're rolling with a rolling pin, and now you're using the giraffe cutter. So I have really become a sportscaster in my sessions, even with in my ABA sessions. And the last letter, E, enjoy. We want everyone to be happy. It's playtime. There's no pressure. It's adding warmth to the play. And I think we have an ABA connection here. Obviously, this is a lot of positive reinforcement, but there's also a pop quiz. So what is this most similar to in ABA? I love seeing these numbers go. This is fun.
Yeah, I love these polls. They're awesome.
Wow, I'm surprised that it's coming out pretty close between two. Interesting. Okay, so it looks like the poll has ended, and it looks like pairing just edged out natural environment training. I'm a little surprised at that. I thought this would be overwhelmingly pairing. Yes, we're very much pairing here. We want to be that really positive and joyful person with these kids, because we want to bring that anxiety down and we want to bring off that pressure of the speaking. And but I can see natural environment training, okay, maybe a little bit, like, right, it's play-based and stuff like that, but we're not really training and doing any teaching at this time. So this is a bit more of the pairing, on the pairing side. Great.
Also, what I think is so interesting about and amazing about CDI, sorry to jump in, is that, and Claire, I'm sure you can attest this, once you start talking like this a lot and the parents start talking about it and the teachers start talking about it and talking and using these skills, you can actually see the child's anxiety go from all the way up here to down here. They know what you're doing. Again, we're so transparent, but they know, oh, my mom is doing, they're not going to call it CDI, but my mom is doing those things. She's talking like that. She is not going to ask me a question right now. And so you'll see their anxiety go down. Same thing at school. We tell teachers to do this as kids are walking into the classroom, or if they see their anxiety go up, and you will actually see the child's anxiety go down. And it's I mean, I think it's amazing. I know that I just love this treatment, but it really is amazing to see how they progress and how they pick up on the way we talk to them and what we're doing when we're talking to them a certain way.
Yes, exactly. Okay, great. So again, we are during this phase of treatment, which actually should be occurring every single time we get together with the kids, and the parents and the teachers are doing this outside of our sessions as well. So this is happening a lot. During these times, there is reflections and labeled praise are constant. We're constantly repeating back what they're saying when they're saying things. It's not a requirement for them to speak, but if they do, we're going to repeat that back and we're going to follow that up with label praise. We label praise everything, right? That's our behavior specific praise for UPCBAs. And we are pairing this with stickers, brave talking points, check marks, stars, like whatever is appropriate for the age. This is obviously going to reinforce and shape more talking. We eventually fade out these stickers. Once, I love that this is one of the things that is how always stuck in my head that Chelsey has said is, once a child speaks in a certain situation or to a certain person, they're now expected to always speak. And they typically will, right? Chelsey will say, like, once they make those gains, you're not going to necessarily or typically see regression. They will, once you're in, you're in. So they're not going to need these stickers anymore. We're going to now move these stickers and these talking points or whatever we're using for specific goals, like maybe asking for help, talking to peers, raising a hand in class. And at the end, we can go over what some of those goals might look like. So our connection here is pretty obvious. It's individualized positive reinforcement systems. We make sure that there is a reinforcement system in place. It's super important. We want to obviously always be motivating and reinforcing speaking, brave talking. Okay, and the don'ts of CDI. Again, we're not asking questions. There's no commands. We're not going to assume what the child is thinking, so we're not going to mind read anything. And we're not going to tend to negative behavior. Not necessarily that this happens often, but it's possible. So what we're going to do is ABA connection. We're going to, you can click. We're going to plan ignore. We're going to put these behaviors, those negative behaviors, on extinction, right? We would do that anyway, I would hope. So here we want to make sure that we are reinforcing what we want to see and obviously ignoring, putting the other behaviors on extinction.
And one of the things about mind reading, what we mean by that is, like, kids with selective mutism are super, super, super amazing at getting people to know what they need without verbalizing. So if you've ever seen a kid with selective mutism, they might point, they might like take your hand and they might bring you to their snack and go like this to show you that they need it open. So there's different stages, and we talk more about that in the training, but basically if a child is doing that, we're not going to say, oh, you want me to open your snack? Because that would be mind reading. And so we really don't, again, back to that cycle, we want to make sure that we're not mind reading, because we can get a kid, like I've seen so many kids in like 3rd, 4th grade who literally have every need met by never using their voice. And then again, it's that negative reinforcement cycle that we really, really need to break. So we talked a lot about what do we do when kids aren't talking or aren't ready to talk. Now we're going to talk about the verbal directed interaction. So VDI. So this is a time when child is ready to be prompted to speak. So we typically know when they're ready when you see that they're engaging. If I see a kid that's hiding under the table, I'm not going to ask them a question. If I see a kid that's like visibly shaking, I'm not going to ask them a question. So we really need to get them a little bit more engaged before we ask them a question, or else it's just not going to happen. We're always continuing using CDI skills. So it's really important that CDI is like throughout our entire relationship with these kids. So ways to prompt for verbalization. So there's very specific ways. So we start typically with a forced choice question. So do you want to play with the blocks or do you want to color? Is this green, yellow, or something else? And then we move over to open-ended. So what do you want to play? What color is this? And I'll continue to talk while you're filling out the poll. And the same thing with direct commands. Tell Chelsey what game you want to play. So this is especially important when we're trying to get kids to talk to someone else. So when we're coaching the parents, we might not have, like, let's say Claire was the one that was coming into the room as the stranger. I might have Claire not ask a question first. I might coach mom to say, tell Claire if this is green or yellow. And sometimes that's easier for kids because the question or the prompt is coming from mom instead of a stranger. So we typically will use that. We want to avoid yes, no questions. And the reason is, like I said before, kids with selective mutism will often respond non-verbally. And so we really want to avoid that. And I'm gonna get to next slide after the poll is closed about what we do when that happens, because it will. All right, Claire, take it away with the poll.
Okay, great. So our AVA connection here, right? There's a lot of verbal behavior going on here, right? So what verbal behavior is being really mainly targeted? And you guys are right. This is heavy intraverbal of answering questions in particular. And then, interesting enough, Chris and I talked very quickly about there actually can be some mansing that happens in here. It may not be pure mans, but there could be like an intraverbal type man, right? What do you want, this or this? Or even open up to question, what do you want? So that can occur as well, but very, very heavily intraverbal. Great job.
Okay, so this is the VDI sequence. And basically what we do is we ask a forced choice, open-ended question or direct verbal command or prompt for verbalization. So it will look like something like this. So is this green or yellow? You wait 5 seconds after you ask the question. Now, I am going to tell you that this is the longest 5 seconds of your life. Even now, I probably treated maybe over thousands of kids, and it still gets me a little bit anxious when I'm waiting for those seconds. So you wait 5 seconds. Let's say that they say green. You say green. Thank you for telling me. Sticker. That's the best case scenario. Then another scenario is, let's say you say, is this green or yellow? You wait your 5 seconds and you get no response. If you get no response, I'm starting to think, I'm like a detective in my head. Okay, they're already talking to me, so why are they not answering? Did someone new come by? Is it a hard question? Do they not know the answer to the question? Were they not paying attention? So you're trying to figure out like what happened there that they're not responding. So you wait those 5 seconds and then you reformat or repeat the question. Typically, I'm assuming that they might not know, or they might have difficulty making a guess. So a lot of kids with selective mutism do have anxiety about the wrong answer. So I might say, is this blue, green, or you don't know? I then wait another 5 seconds. If they say it's green, I treat it like they answered the first time. Green, thank you for telling me, sticker, and I move on. If they don't answer, so if you say, is this green or blue? You wait your 5 seconds. They're not answering at all. You then say, is this green, blue, or you don't know? You wait another response, another 5 seconds. You don't get a response. Then I'm thinking, okay, they're not able to answer this question in this moment. So I might say to them, again, back to transparency, this is a hard one. We'll come back to it. And then I'll pull them aside to where they were last verbal. And then I'll start doing CDI again with them, maybe alone. Maybe I'll go back to, like, let's say I'm in the classroom and I notice there's a kid around me. I might pull them to the corner and I'll just do CDI for a little bit, get them warmed up again. And then I'll ask them that same question. Is this green, blue, or something else? If they answer me green, oh, thank you for answering me right away. And then I'll slowly move back to where I was so that we can get them successful. If that still doesn't work, then again, there's always plan A, B, C, D. I always say this to parents and teachers because a lot of times they get nervous. They're like, well, what if he doesn't answer? Or what if I make him more anxious? And we might make them a little bit more anxious. So we always go back to where they were last successful. And I think that's really important, and being confident that that's okay. Let's say we say to them, is this green or blue? And they start pointing. We're going to acknowledge that. I see you're pointing. If I know that the kid is especially anxious about making a mistake, I might say, I see you're pointing to the green. Is that green or blue? You wait your 5 seconds. If they respond, green, thank you for telling me, label praise. I often will say, like, when I tell people to avoid yes, no questions, I mean, everyone's going to ask a yes, no question. So I say, it's not like I'm going to ding you with a buzzer, right? If you ask a yes, no question, you're not in trouble. Just when they go and nod, which they likely will, I see you're nodding your head, tell me yes or no. Typically then kids will say yes or no. And then you reflect and give that label praise. So what we don't want to do during VDI, so we don't want to give indirect commands to talk. So can you tell me what color that is? Can you tell Chelsey what color that is? I think this is similar to when we give commands to kids. We don't want to say like, can you pass me the salt, or can you clean up your toys? Because you're giving them that option to say no. And again, even if these kids are really motivated, anxiety is really hard and it makes them uncomfortable. So if given the option, they likely wouldn't be verbal, especially in the beginning. We also don't want to give rapid fire questions. This is actually hard. Once kids start to talk, we get really excited. So we start to ask them lots of questions. We really want to go to CDI in between those verbal prompts. And we don't want to enable, which we're going to talk about in a second. So the difference between enabling and accommodating is really, really important in this treatment. So accommodating, which by the way is different if you treat kids with OCD, accommodation is a no-no. Here, we like it. So accommodating is meeting the child where they're at. It's the scaffolding that we talked about before, and we're helping them be successful. So an accommodation might be something such as the class is given an assignment to do show and tell. If we tell a kid with SM who's early on in treatment to do show and tell, that's just setting them up for failure. But an accommodation would be having them either A, meeting them where they're at, so maybe they can videotape it at home with their parents and then show it to just the teacher. That would be an accommodation. So helping them participate in whatever way they can. Enabling would be rescuing the child. So let's say, again, the teacher assigns show and tell to the class, and they might say, you know, Johnny is not going to do it. So don't worry about it. He doesn't have to do show and tell. That will be enabling, because basically, one, you're not letting them try, and two, you're just letting them get away without doing it. And so what is that teaching them? Again, that negative reinforcement cycle that they don't have to do it. What's also enabling is staying on the same step for too long, not moving forward. This is my biggest thing. Once kids start talking, we expect that they will continue to speak in that situation, and then also in a little bit of a harder situation. So if Johnny is able to do a video of show and tell, well, the next time or the next situation we set up for him, we want him to be able to do it. Maybe it's still video, but maybe it's the teacher watches with one other peer. And we'll talk a little bit about goals in a second, but we're always moving forward. We're always checking in with the teachers and saying, okay, it's so great that he's talking. Now here's the next step. And also we don't want to contribute to that anxious avoidance. So what is accommodating to one kid may be enabling to another. And what is accommodating to one kid will become enabling to that kid in the future. So we're constantly thinking about our next step.
Sorry, I just realized I was muted. Again, we're talking about shaping here and that negative reinforcement cycle. So there's that little AV connection. Okay, so now talk about fade-ins. Fade-ins are super, super important. Okay, these are typically done when we do those big chunks of time, these right after our baseline. So immediately we want to start fading people in. So what does this look like? So we have the child and the familiar adult, typically the parent, playing alone. The adult is being coached by me or one of the other clinicians, whoever is the lead clinician on the case. They're being coached through CDI and VDI, reinforcement systems, and making sure they're doing those reflections, labeled praises, and giving those stickers. After some time, once we see they're really comfortable and successful, we send that stranger in. And again, the stranger could be another clinician or a intern, and they're just going to pretend to do something else while the familiar adult continues doing those CDI and VDI skills and reinforcing those verbalizations. After some time, the stranger is also being coached by the lead clinician on what to do. We're going to have to move a little bit closer, and eventually they're going to join the play. Typically, we have like 3 sets of toys out, so they might play with something different at first, and then we're gonna lead them to come closer, and then they're going to start playing with the same toy that the other child's playing with, whether it's like Play-Doh or Mr. Potato Head or blocks or whatever it might be. So they'll start playing, and I see our 4th poll popped up. When I'm talking here, try to think, what does this fading in process sound most like to you? And they're going to start playing. So, but the familiar adult's going to continue the CDI and VDI and the reinforcement. Then the familiar adult will prompt the child in front of the new adult and reinforce for answering in front of the new adult, right? So they're doing those VDI skills, but the child is still speaking to, let's say, the parent, but the stranger is right there playing with the same toys. This is going to be repeated several times, and then we're going to start to transfer that over. Then the new adult, the stranger, is going to start prompting for those verbalizations, voice choice questions first. And then with some time and when we see they're comfortable, then we'll have them start to ask some open-ended questions. They're going to take over the reinforcement system. The familiar adult starts to back away and eventually leaves the room. Of course, with that transparency, I'm going to be right back. I'm going to go use the bathroom. I have to go talk to somebody at the office, and I'll be right back. And they leave. So once that happens, then that lead clinician, once we have one person faded in, that lead clinician is going to fade themselves in, right? Because I want to make sure when I'm working with a kid that I'm able to speak with them and that they speak with me. So I'm going to fade myself in, and then as much time as it takes, or as little time as it takes during these really intensive treatment sessions, we'll determine how many strangers we can fade in. We aim for, I would say, usually like 3 or 4 if we can. Sometimes this can go very quickly. I was able to fade in my first stranger in like 15 minutes. And then other times it could be over an hour, 2 hours. It could not even happen in a session where the familiar person, the parent, is completely faded out. So it's like Chelsey said earlier, it's very, very different, the dose dependency is going to be very, very different. Yes, generalization across people. Very good, guys. Awesome. Okay. We also will do this in school. You already got your pop quiz already popped up already. So we'll do fade-ins in school as well. And we want to make sure that I'm going to go in, the child now speaks with me, I'm going to go in, I'm going to fade in those teachers, I'm going to fade in those students, I'm going to fade in whoever it is that these kids aren't speaking to in their school environments or other environments that might be relevant. Okay, exposures. These are so fun. This is essentially like a community-based outing, like we to do with a lot of our kids. We're going to really test them and push their limits here. And we're going to bring them out and make them ask for ice cream. And we're going to put them in these situations that they're really, really afraid of doing. We're making sure that this is promoting generalization. We're increasing their self-efficacy. And this is their belief that they can do it. They can speak and they can do this. And then they can be successful. We're transparent through the entire thing. We're telling them every single step of what we're going to do. So there's no surprises. We're only changing one variable at a time. We're not going to throw them in the lion den, in the lion pit, and like, good luck. We are going to make sure that it's done in small increments and they're super successful along the way. Okay, so our connection here, shaping, we're desensitizing, right? There's some systematic desensitization going on with this graduated exposures that we're doing. And of course, we're generalizing. This is always shaping and generalizing. I feel like this comes up so much in what we're talking about, what we're doing.
So I had some examples of some goals that we typically will give kids. So let's say the goal is talking in front of a class. So an example of what like an exposure hierarchy would be, or the steps that we use. So one would be talk to teacher alone in the classroom. Then we would have him talk to the teacher alone in the classroom with 1 to 2 students. Once he's successful with that, talk to the teacher in the classroom by her desk while the students are working, so not really paying attention to him. Then it would be answering a planned question in front of the class. So like the teacher might say to Johnny, okay, right before class starts, they might say something like, okay, what did you get for homework on, what's the homework number 2? And he might say 4. Okay, so when we go over the homework, I'm going to ask you about number 2. What are you going to say? 4. Great. Let's practice that one more time. When I say we're going to go over the homework and I do number 1, someone's going to answer, then I'm going to get to number 2. What are you going to say? 4. So much practicing. Sometimes it does feel like beating a dead horse. Claire, I remember when we were doing the ice cream the first time, it was like the kid looked at me when we were walking towards ice cream. It was only 2 blocks away. We must have practiced 100 times. And at the end, they probably wanted to kill me. But we really want them to know exactly what it is that they're saying. So we take away every other variable, especially the unknown. So that would be step 4. Then step 5 would be answering a spontaneous question in front of the class, which means that they wouldn't really prep for it and the teacher would just call on the student. This can all happen in one day. This can all happen in 1 week. This can all happen in 2 weeks. So we're always making sure we're moving forward. Let's say we get to step 3, and I'm just mindful of time, so I'm going to talk a little faster. But let's say we get to step 3 and he's not able to talk to the teacher in the classroom by her desk while all the students are working. Then what we do is we go to 2.5. We talk to the teacher alone in the classroom with like 3 or 4 students, and we slowly increase the amount. Last example that I'll give, show and tell. Write out show and tell outline with parents at home. Practice with the teacher in the classroom. Practice with the teacher and the peer. Do the show and tell in front of 1 to 2 or 2 to 3 peers, and then eventually in front of the whole class. Again, we go back and forth as needed. And sometimes we even use videos for this. So it depends. It's like a game. You're always thinking about what you're doing next. And you're also coming up with, I want you to take risks. Like a lot of times we'll say, well, what if they don't answer? Well, that's fine. Then we'll back up a little bit. But I'd rather us try and not do great and then go back and then get them successful and then try again, because we know that these kids could really do it. So I'm going to skip this one because this is a little bit more advanced. And then just the last thing that I wanted to add about additional treatment, there's also some intensive group treatments for children with selective mutism. Basically, it simulates a school day setting. The counselors are trained in selective mutism, and then they work with that child doing the very things we talked about, raising their hand, answering questions, talking to peers, and it's really, really effective. And again, that's in the reference page. So I see that this is code 2. You need it for your credit. And so we'll give you some time to write that down.
Write down code 2. The word is fade-ins. Fade-ins.
I'm super impressed that we got all that information.
I
know. We tried to cut it, but there was just so much that we needed to share.
Yeah.
But I'm sorry we didn't have time for questions. But if you want, Kristen, I don't know if you're okay with people emailing questions or however you want to handle that, but I do apologize that we didn't get time to answer.
I think this was great. There are so many great questions. So what I'm going to do is I will email Chelsey and Claire the questions, and we will pick a few and post them on Instagram, and I don't know, wherever else I think we post on Facebook, Instagram, and wherever else. So follow us, follow Manhattan Psychology Group, because we will be posting answers to some of the questions that you put in the Q&A, because the questions are great. I'm really curious to see the answers.
They are. I wish we could go through these, but we need another hour.
Exactly. We are a minute over. So